Time for Action. Today's webinar will be presented by Dr. Zinat Hijazi, Associate Dean for Medical Education and Professor of Pediatrics at the School of Medicine of the Lebanese American University. She planned and implemented an integrated medical curriculum for the school. Dr. Hijazi has a long-standing career in pediatrics and medical education with more than 12 years of pediatric practice in the United Kingdom. Dr. Hijazi previously held the position of Professor and Chair of the Department of Pediatrics at Kuwait University Medical School. In parallel, and as a Professor of Pediatrics, Dr. Hijazi initiated the first pediatric asthma clinic in Kuwait and was first to publish on RSV, respiratory syncytial virus infections in children in a desert country, as well as on gene mutation in Kuwaiti asthmatic population. During the session using the chat feature on your screen at the bottom of the screen. And Dr. Hijazi will be answering your questions toward the end of the webinar during the Q&A. Thanks again for joining us today, and I'd like to welcome Dr. Hijazi. Please go ahead.
Hello, everyone, and good afternoon. Thank you, Ala, for your kind introduction.
You're welcome.
Thank you. And I would like as well to thank the organizers for inviting me to deliver this webinar as a part of the continued activity of the AAHCI, the Association of Academic Health Centers International MENA region. The topic of this presentation, actually, or webinar, is a direct response to the excellent meeting that was held last year at the AUB. It was on medical education in the new era, humanism, technology, and the physician of the future. The meeting was excellent and stimulating and as well provoking. I personally believe that the making of the physician of the future should start in the pre-medical years, and hence the topic of this webinar, where I hope we can get together and reach on to something that is useful in this line. No, why is this not moving? Sorry. So, what dictates the profile of the medical applicants? These are the drivers of change in medical education. They straightforward affect the portrait and the profile of the medical applicants. And these drivers are too many. We start by the patients. We all know that the patients of today are unlike those in the past. They are so knowledgeable, they have access to information, they ask too many questions, they want evidence. I'm not going into the details of that. We all know about that. The payers, of course, play a major part. New technologies, and as well the interaction among members of the healthcare team, the investors, the medical innovators, and the constant call for cost efficiency and quality management, as well as new healthcare deliveries. These are so many things, and there might be few more, but these are the major, actually, drivers of change. You know, for the discussion of today, I'm dividing these into 4 major areas. The fourth one, which is number 1, and we usually rely on, the traditional requirements from NCAT, GPAs, and interviews. I left it as number 4 because I thought the first 3 ones are going to have influence on the components of the 4th, which are the advances in medical sciences and technology, humanities and narrative medicine, and the role of interprofessional requirements. Now, artificial intelligence, I'm not going to go into depth there. We all know what it's all about, that the machines will be doing some of our work, and they may even be able to take decisions like we do. So where does this take us? This is going to affect, actually, what we teach our students and how we teach them. And this will affect their whole profile, the pre-medical requirements, not just pre-med, as well as graduate students. We should not forget here our teachers. They need as well to be helped, and we need to work on them too. We really need to emphasize tech literacy, computer coding skills in our undergraduate courses. We need to develop as well standardized courses in basics of artificial intelligence and the machines, that really work and how they work, and make them aware of the thought process of these instruments to make them use them properly. Not just this, we have simulation and augmented reality. This is with us already. Many schools now, or majority of medical schools, use simulation and augmented reality as a pedagogy of teaching and evaluations. And not just that, even in real life practice, these are playing, a big role. We cannot go in depth of all this. Having said all that, the educators need to have their wisdom, on what we really need to give our students. We need to open their eyes to the advantages, limitations, and as well the challenges. In brief, okay, we would welcome, the analysis of a huge amount of data that we will be able to have. That's wonderful. We might be able to reach a faster diagnosis. A diagnosis is even with more precision. We do welcome all those things. Few things on the other hand. What will happen to the gap in health disparity? Is it gonna get bigger? Would these devices, and opportunities be available only for those who can afford it, and then the gap is going to be wider? Or are they going to be available for everyone because other means may not be available? We don't know. And unemployment is something else. Whenever artificial intelligence comes into any profession, unemployment is a major, major concern. It's all over the media, and I'm not gonna go into that, and we all know it very well. And in addition, in our profession, I think what is very important is the doctor-patient relationship. What's gonna happen to it? With all these machines coming in, are we gonna be away from our patients? Or are we gonna have perhaps more time to spend with our patients, to explain to them, to support them, and follow them up? We don't know. We need to wait and see. So we go to personalized medicine. It's actually the sequencing, the whole sequencing of the genome has enabled us to identify genes that are related to certain diseases. We all know. I'm not going into depth in there again. Cancer is a very good area, and plus other diseases. It's not just genes related to diseases, but as well biomarkers that for that specific disease, whether cancer or otherwise, yes, it tells us who is gonna develop it, and if, like the likelihood of developing it, what is the likelihood of this patient having severe illness within that very severe same disease versus those that are gonna have mild disease. Who is gonna respond to which type of treatment within the same kind of disease, particularly in cancer area, a lot has been done. But it's just not that in cancer. Across the board, asthma as a pediatrician, now chromosomes is identified, and then the biomarkers are there telling me not just who is liable to develop asthma, but the biomarkers are telling me who's gonna develop severe asthma. And when it comes to treatment, for the first time now, I know the patients that we've been giving them steroids for like prophylaxis, which is the mainstay of treatment, some of them don't respond and we get stuck what to do. Now we have biomarkers telling us that this patient is a non-responder. So from the beginning, save pouring steroids into him. And because of that now, there has been new modalities of treatment started, that can be used instead, like the anti-IgE antibodies and the rest. I'm not going into more. So, but to show that it's not just cancer, it's across the board. And mobile health technology. Now, this is something, that is with us, and you're all going through this experience, to the extent now that the World Health Organization made a definition for it, like the medical and public health service, which practice supported by mobile devices. So you might have in the future your patient sending you like a chart of his blood pressure or blood sugar or a follow-up of his weight. And then you look at it and you tell your patient, okay, all good, you don't need to come to the clinic. That is canceled. Or you may need to come. The patient may send you as well, like something like, I'm not feeling well, very tired, this and that. What shall I do? come to the clinic or do otherwise. In addition, the patient would be sending you this information maybe at his leisure time, so convenient for the patient. So in the end, maybe there will be lowering of costs. And however, what happens to the outpatient clinics? Are they going to be abandoned? I don't believe so. But then they will have to have radical rebooting, actually, if anything. This is something in the future. Having said all that, we have challenges and opportunities. Right. Is this patient gonna be in contact and send messages or pictures 24/7? Or are they gonna be like just doing that during work hours? There has to be some regulatory rules over there. And I think in Lebanon, we have a lot of, the phones being used by patients to their advantage. This needs regulation as well. Humanities and regenerative medicine. This is what medicine is all about since its inception. It's about helping. It's about, number one, by listening to the person for what's hurting him, what's his problem, analyzing it, trying to get to the bottom of it, examining him thoroughly, give him a diagnosis, support him, give treatment, encourage him for follow-up and for compliance. This cannot, be compromised at all. And if anything, we have actually now to overemphasize this. And our students, even from pre-medical years, they should, acquire deeper knowledge of medical humanities, which we all know, empathy, communication skills, ethics, and all the rest of that, which is extremely important. And these are usually provided by liberal art courses, too many of them. We have them in all our schools. Maybe this is the time where we have to say, like, although we know our pre-meds, they do take like courses, but maybe we need to say, look, these are the courses that you really need to have, a must in liberal arts, and plus others that might be left as optional, as we feel necessary for the profession. Not just that, we really need to include, these lab courses as a thread, even in the medical school and the clinical years. This is a challenge again to our teachers, the role model, and then there's something else that we need to do for our teachers too. What about interprofessional education? Now, it is with us. We cannot work in the health sector separate from one another, And these programs, they fall into three parts: to be good and to work. There's a didactic part, a community-based experience, and interprofessional simulation experience, where we should have students from the different schools together attending all those activities. Now, being together is something that's gonna help them understand one another, how they work, appreciate the value of one another, and that they are just like, part of a chain working together to deliver good health care for our patients. Some schools, they have it as an add-on thing, but it should be an integral part of the curriculum. And students in pre-med years, they can do some inter-professional, studying and work together. In the United States, out of search of all those things, like the US, there are 3 best practices. Like I put them because if you'd like to get into those programs, they are detailed and really beautiful, a lot to learn from them. The Rosalind Franklin University of Medicine and Science, University of Florida, and University of Washington. Like now at the LAU, we have not as an integral part of the curriculum, but as an add-on thing, like the IPE, where students from medicine, nursing, surgery, pharmacy, social sciences, and nutrition, they all get together to do these 3 activities, but they have to be part of the integral curriculum, if anything. Interprofessional education doesn't stop there. We have to think of incorporating core pre-med courses in non-traditional majors. Non-traditional majors, I go as far as business schools, engineering, and so on, as optional. Because should they think later of doing medicine, then they have had a feeling of that and they have been prepared somehow. And other schools like nursing, nutrition, pharmacy, you know, like many times we had students applying to us after they finish nursing or pharmacy, and they find that they have to repeat like a year or two before they join us. And if we introduce part of our core courses into their requirements as optional, then those that have in mind becoming doctors, they would actually save some time. We have in the past admitted students from the business school, and a student actually from the business background, he turned out to be our valedictorian from School of Nursing and turned to be an outstanding student too. Not just that, now with the students in pre-med years, they should be able to do some projects together. I've just come back from a conference in Japan, Tokyo, and a prize winner was in that conference, a student. Among a group, they were a group of students, medical students, they were together with students from School of Engineering. Then they created a machine as small as a cell phone, connected to a wire, to a diaphragm, you put to the chest, and then it actually writes to you what sounds are there, whether the breath sounds are actually bronchial, vesicular, whether there are added sounds like wheezing, crepitations, coarse or fine crepitations, you know. And the main thing is that during their discussion, they said it was a great eye-opener for them. When they were in the making of that machine, they could understand its limitations and its challenges. And I think our pre-med students, they can do something like that as a part of their research, just as an idea. And at the moment, you know, there is something going on at the LAU as well in the medical years, like a program between the School of Medicine, a course, and engineering. You know, Dr. Sola Bahouz and Tekli together, they are doing it, and the students are working on something similar of the kind, either to come up with a device or perhaps a paper over that. So what about now traditional requirements? We know the MCAT. We start with the MCAT. It started, we all know, in 1928. And then the AAHCI launched another version in 2015 into its 4 components, and we know that there has been a lot of emphasis on critical analysis and reasoning skills, the social, and all that part as well. I'm not spending much time. The new MCAT actually, it doesn't just test the knowledge. What's more important in it is the ability of the student to use that knowledge for reasoning. If you look at the pie chart here, you find in the past, you know, the one on the left here is the sciences, and on the right is the non-sciences. In the past, this part used to constitute only 27.8%, less than 30. Now it's about, with this system, constitutes 50% of the questions in the MCAT scorecards, critical analysis and reasoning skills, psychology, sociology. Bio is not biology. This is biological foundations of behavior. How important that is. This came at the expense of some of the sciences. They've cut down on some of the physics, chemistry. I'm not going into depth. And some of the biology, like bone metabolism and so on, that they've introduced the biotechnology. Having said all that and reviewing the literature regarding the MCAT, because it's still the gold standard, you know, you still see a lot said and written, right? Students kill themselves preparing for the MCAT. What is the value of the MCAT actually for them as practicing physicians? There is no right answer there. But at the same time, you know, the heads of the MCAT, you know, program at the AAHCI, they defend this and they say that this science part is actually a better predictor of ability of the students than university grades, than the GPAs. Because university grades can be very variable, and that's true. Another argument, and some evidence over there, is that this science part, there is some evidence as I was searching for this presentation too, that the science part actually can predict better who is going to do well during the first 2 years in medical school, but nothing mentioned about later on as practicing physicians. If we look at the schools and what they are doing, it's interesting to see that the University of British Columbia and McGill, they take only the humanities part of the MCAT score, social part, and they don't consider the part that is on the left. But they have their own prerequisite of courses in sciences. So this is what is happening in the world, and this is where we are. We have to think very well. So just here, you cannot go without really mentioning the experience at the Mount Sinai school, where, like, not in depth again, but I will say, like, group of students that were admitted with a background of humanities without taking the sciences, and the other group conventional entrance. The performance were similar during the medical years. However, there was like a more tendency of the group that with the humanities and social majors to take like primary care and psychiatry, avoiding surgery and anesthesia compared to the other group. Well, fair enough. It takes all kinds to make the world. We need all kinds of physicians. On the other hand, we have the Wandelbergs School of Engineering example, like where they have done a wonderful thing here. The link is available. You can and see the details where they managed to prepare their students for medical schools while they're doing their degree in computer science. On top of that, with the normal load in 4 years by creating pre-med track. So you see, things can be done if they were thought of well. We would welcome students from engineering schools in our schools. And if we look at McMaster as well, since it opened its door in 1969, they've been accepting students from across the board, from all backgrounds. The GPA, now we talked about it, in that it can be variable. So what about the interview? Why the interview? Because this can tell us what more is there to the candidate than just the grades. And that's very important for us. It's about personal traits and attributes that we care for our students to have. So usual panel style now is getting out because I've looked and the evidence, it is not predictive of a better outcome. The outcome here is a practicing physician in whichever specialty. And it's disappearing. MMIs are taking its place. That's the multiple mini interviews, usually around 10, 15, 12 stations. Every student goes through, and the interviewer is usually a faculty or could be a resident or someone from the community. The case, it all rotates around ethical dilemma and problem solving. It could be a written case or a paper case, a video or standardized patient simulation, and so on. It is less subjective. It's been found to be less subjective than a panel interview. And the other thing, like studies show that the MMI correlates better with clerkship AAHCI. Well, that's good enough, but not perfect, because AAHCI is not real life situation. It's an exam. And the students are gonna do their best and look their best because they want to get the best grades. Still, it's not bad, but we need something better. We need longitudinal studies to find out if the MMI predict actually the practice, their work as practicing physicians. So what do? We have to look carefully at the MCAT, at its components, the GPA, and the interview. And what's the percentage of each that we are going to give? What are the numbers that we are going to give each of them? This as well needs some work. So really here, there are pieces of puzzle that come together to make the portrait now for what we really need for this medical applicant. It's basic medical sciences, artificial intelligence, bioinformatics, and this is like biology combined with statistics and information technology. Genetics, which is going to be very strong, all these together. At the same time, humanities and narrative medicine. Humanities are very, very important for our undergraduates. Scientific research. The critical thinking should go across the board. The role of engineering, students, we need to encourage them. We need to encourage them to join medical school, and what can we do to help in that regard? And diverse background, and of course the IPE, like everywhere. So who's gonna do that? It's us. It is our responsibilities. In a school of medicine, educators, this is a call for all of us educators to get together, work together, see what we are gonna do. We cannot do it alone. We have to be together with our colleagues from arts, schools of arts and sciences. They will help us with the sciences that we need to deliver, as well the courses, nursing, pharmacy. We need to get together too with them to see how we can help. What can we incorporate as well in the school of engineering to work together in interprofessional education, never forgetting the business school. And then of course here we have research, and then the MCAT, as we are gonna keep it properly, is gonna stay. I've left here a couple of as well pieces of the jigsaw because I know there are other compounding factors that are gonna be there and we have to look into. So the change of anything is here. And there is an obligation on us, medical educators, to provide medical candidates with the tools and the environment so that they become what we want them to be, efficient and proficient human healthcare providers of the future. Have I said that? I am a strong believer that although we need to restructure the pre-med curriculum, this should be inclusive without adversely affecting the length of education. They've already gonna go through long years. With this last slide, I'm closing with some thoughts in there. If you agree with me, and open for discussions, even on other things. Measuring knowledge is the easiest to do. We definitely need to develop more sophisticated ways of measuring other capacities, including longitudinal studies that might predict outcome practicing physician. The balance is not going to be easy between basic sciences, AI, genetics, bioinformatics, and the humanities. But humanities, we have to focus on a lot as well. We need to promote diversity among students. By this, we can encourage this by integrating core pre-med courses and non-traditional majors. Another point, what about the conformity of admission requirements among medical schools? We've seen in the States, in Canada, people do different things, and probably we're doing the same in Lebanon. Do we have conformity? And in Lebanon, we have as well the American system versus the French system. American system, where students are admitted after having spent 3 years in sciences. The French system, they take it immediately after the baccalaureate. What can be done here? Another final point, as I was looking into this matter, is that the cost of medical education is a significant concern. And a lot has been written about this now. Will it be the purview of the privileged? I'm just gonna close with what Joseph Flinker wrote. He is from University of British Columbia. He said, physicians should in some way mirror the population they are treating in racial, ethnic, and socioeconomic activity. Thank you so much for listening. Floor is open for discussion, and it's been a pleasure. Maybe I can
Thank you, Dr. Hijazi, for hosting this webinar and for this very informative webinar. Please, everyone, if you can start typing your questions on the chat feature at the bottom of your page. We have a question from a chemistry pre-med student. The requirements of pre-med courses for chemistry students to apply to medical school are different than those of biology. For example, chemistry students are not required to take biology 2 and genetics. If I want to apply to LAU, am I supposed to take the biology 2 and genetics?
Usually, yes, I would think. To take, you need to take the biology, yes, you need to take that. But I would, at the moment, just advise like to inquire with the admissions office, you know, for those detailed requirements, just in case, you know, my answer wasn't quite right regarding your, my answer not quite right regarding your question. But that's an important question. That's why what we are trying to do here is to see how we can save time by adjusting, you know, the pre-med requirements. We've changed many things throughout the years for the LAU, but I would double check with the admissions office. The details are there and on our website.
What do you see as the most effective way to implement change? Can we hope to convince pre-medical programs to make modifications, or do we in the medical schools have to first change our admission requirements and the others will follow? It could be a slow and complicated process of change.
The change is going to be slow and challenging, you see. And no single school can do something on its own, you know. Number one, we're still bound to the MCAT, you know, requirements, you know, especially in our part of the world, you know, you still need to take the MCAT. We still consider the GPAs, you know, of our students and the interview, but it remains an internal matter for us to play with the details, you know, on the sciences. You may remove one part and introduce something else, you know, or you may give it the weighting, you can lower it to increase the weighting of other things. But educators need to get together, you know, based on the changes in teaching medicine, where we are going, that these changes need to be implemented in the preclinical years. So clinicians, medical educators from the schools of medicine, together with our colleagues in School of Sciences, you know, need to get together into this and decide what is best, how much is needed of basic sciences, you know, how much is needed of behavioral sciences for our students. Individual schools can do now, I suppose, what they really find best, as long as they consider the MCAT scores, because if the students need to continue in the States, you know, that's an area that they can do whatever they want. We've been changing our some of the details of the requirements for admission at the LAU. You know, we've been changing things all the time based on, you know, results and changes and the recommendations. But it's best if medical educators get together, brainstorm together, and get the best for medical, for pre-med students.
Okay, one more question. My colleague and I are resident physicians in internal medicine. Much of the transformations that you advocate for in pre-med years, we did not have the chance to experience, but we too will be part of the global transformations in medical practice in years to come. What is your advice for junior physicians like us in building our skill set and profile during this day and age in medicine?
It's all the things that have been mentioned here. Thank you for the question. You know, as preparing yourself for medicine, like, I don't know which major you're doing, but actually you need we need to provide you, with the proper courses, the proper tools and environment by which you can develop skills, like bioinformatics at the moment, and all those are very, very important. Like, I believe now, like bioinformatics, maybe it should be a must as a requirement to enter medical school, which was not in the past. We're admitting, now with bioinformatics background, but it's not a must. Perhaps it should be a must. So really building experience along those lines, is going to be very, very helpful for your future. And as well, remains as well the duty of the educational body to provide this interprofessional education, work together with students from schools of engineering, but that cannot be done at the personal level. This has to be arranged, for you by your educators. So this area is very important. And like I said, the humanities as well, the lab courses, you need those. You must have plenty of those, because they are the cornerstone of really dealing with patients of the future. And for you being good, listening and caring physicians. Genetics is another area that you cannot really ignore. We've accepted students with a diversity in their backgrounds in genetics. As they enter med ones, some they know a lot, some they don't. I think genetics needs to be strong. You need to prepare yourself very well on this as well.
Doctor, the same person asked, what exactly do you mean by bioinformatics, and where do you think we can get such skills? Online courses, for example, Coursera.
Yeah, the bioinformatics is the science of biology combined with statistics and information technology. The schools, they have a course like that, called bioinformatics. You can, join, and you can learn a lot through that. It's combining these three things together, the science of biology with statistics and information technology. You'll be able to deal, you'll know how to deal with the large information of data, etc., etc. It's so informing, You can learn a lot about it from there. There are programs, I'm not sure if there is something like this online, but it's something you can, one can probe into and find out. But it is available as a course at LU, and I'm sure at other schools too.
Do the traits that medical schools seek differ between the French system, where medical education starts after the bac, and the American system, where students first complete an undergraduate program?
The question was, do I prefer or what? Sorry, I didn't hear that.
Do the traits that medical schools seek differ between the two systems, the French and the American?
Well, you see, the traits, we're talking about the traits here, it's hard to say. In the French system, the applicants here are at a younger age. They've just finished their baccalaureate, and they have to go through the training. So it depends on they really want medicine or not, but still, many countries, they have this kind of system. And whatever of traits is needed, I don't know, maybe at that age they can, you can identify, but the school as well will need to work on them from the minute of entry during the first year on enhancing humanities, like in the American system. In the American system, you do sciences related to medicine, and then you do lab courses, liberal art courses, humanities as well related to medicine, genetics, and so on. And they will know more about themselves, whether they are really into medicine or not. So by the end of the 3 years, they get a degree. They may want to go to do medicine, or they may not, But in the other system, you see, there isn't much choice. You start and you have to continue, unless you drop out. But then, if we say we prepare students for, in the preclinical years to do all those things and humanities, I can see no problem how these things can be as well applied in the French system during the first 3 years as they enter medical school, to prepare them. I don't know in the French system whether they conduct the interviews the same way as we do, for in the American system. Because the interview is the thing that helps, let me say, it's not always 100%. It really helps identify the traits in our applicants. And remember, they are really more mature. They are older, they are more mature than the younger ones just after their baccalaureate. I hope I've answered your question.
Thank you, Doctor. If anyone has any question, please type it now. I think that's it, Doctor. Do you want to add anything?
Well, by the end of this, I would like actually to thank you all for listening and for your input. And I'd like to thank the organizers once more, for running the webinar. And I hope this is taken as a call for us medical educators, like just to start working without delay. Because, as I mentioned, it's going to be like a slow process. It's going to take time. And if we want to implement changes, you see, our applicants need to know this well in advance so that they know when they are going in the pre-med 1, which courses to choose. Is it bioinformatics that's becoming a must, or is it which lab course if it's a must, and so on. So that's why we need to work now and ahead of time to be able to help them. Thank you so much.
We have one more question.
Yeah.
In some medical school admissions programs in Lebanon, the critical thinking humanities parts of the MCAT have less weight than sciences because there's concern about students' ability in English. What do you think about that?
Thank you for the question. Yes, this is absolutely true. Even in the previous format of the MCAT, it was even harder because it used to be, like this part about the American culture, American history, which our students knew very little. So the schools that have opted to really give it less weighting, I think they were right in doing that because that was not representing the actual situation. It would bring their grades down at a time, they were not competing, equally with other candidates. So you see, here comes the wisdom of the people in charge, and to see what is relevant, what is important, based on the goal in the end that we want to reach. And then they can do that. So this has been done, yes, and it's not wrong. And now more is being given to the humanities, more weighting is being given to the humanities, but I don't think it's been higher than that of basic sciences until the moment, no.
Thank you, Doctor, for hosting this webinar again, and we hope you enjoyed it as much as we did.
With pleasure, thank you.
I will be sharing the recording with you and with the attendees and those who weren't able to make it.
Thank you.
Thank you.
You're welcome.